All right, let's take you back to one of our top stories. If you missed it, South Africa will be receiving 1.5 million doses of a COVID-19 vaccine by the end of February. The first 1 million doses are expected this month, and healthcare workers will be the first in line to receive the jab. The health minister announced that this is after an agreement with the Serum Institute of India. Let's get more on those developments and more with Wits School of Governance Professor Alex van den Heever, who is also a specialist in health, economics and finances. Professor, thank you very much for your time. Now, of course, this development is very good news, but how would you suggest that the distribution of this vaccine happens to avoid, dare I say, corruption?
Yeah, it's very difficult to tell exactly how the vaccine is going to arrive in South Africa and what the procurement modality is, because the healthcare workers in South Africa are all on medical schemes, which means that the bill for this should actually be paid for by medical schemes. But that implies that the whole procurement and distribution process is consistent with the way medical schemes actually buy healthcare. And it's far from clear whether the government has actually thought through all of that. The other key problem with this is that the Department of Health's own strategy identified 1.25 million healthcare workers that would need to be covered. And for that, you require 2.5 million doses. And in this agreement, there are 1 million doses short. So it's unclear exactly which portion of healthcare workers they're going to prioritize out of this and how they're going to manage the shortfall. And I think that this is problematic because it shows what happens essentially when you don't have a well-timed negotiating process, because you end up with going to the begging bowl, with a begging bowl to India, and only getting a part of what you want because you haven't really done the work early on. And I think that's going to create problems in distribution as well as in actually achieving the objectives of Phase 2 and Phase 3.
And of course, our numbers are rapidly rising. I mean, yesterday, close to 22,000 new infections in South Africa, according to the Health Department. This month could mean tomorrow, and it could mean in 3 weeks' time. And like you're saying, we are now at a point where we needed to beg for this vaccine to arrive. Are we a little too late?
Well, we're definitely too late for the current surge, which is really problematic because frontline healthcare workers are getting ill and dying in significant numbers, and that is really not right. And this surge itself is going to exceed the earlier surge. It's exceeded it in the Western Cape. It's exceeding it in KwaZulu-Natal, and it's still an exponential increase. And in Gauteng might exceed KwaZulu-Natal and the Western Cape by a significant amount. So we are heading toward a very serious problem in our facilities in those areas. The other problem that we may face is what might happen with the potential winter surge. So that would probably be our expected third surge. So we might contain this particular surge with the restrictions that we've put in place, and it will go down. But we will face a risk which is much more systematic when we go into winter, when people are more likely to be indoors in more crowded spaces, and it'll be more difficult to control super spreading. So we need to have vaccines before April for that particular surge as well.
What would this mean? Excuse me, Prof. What does this mean for our relationship with India and perhaps maybe government trying to use our other bilateral relationships with other countries to try and get this through?
I think that India really did us a favor, and I think it would be very good to keep up with that relationship because India can do us a lot of good. And we have to be fairly ambitious in what we ask for from the Serum Institute. But we also have a huge opportunity with the Johnson & Johnson vaccine in South Africa because they look like they're going to start producing vaccine at scale in South Africa. Although the vaccine isn't produced by us, the final filling of the vials happens in South Africa. So we're going to be producing 300 million doses from March in South Africa. And all of those vaccine is going to come in tubs into South Africa and is going to go out in vials to other countries. And as yet, South Africa hasn't secured a bilateral arrangement to access a portion of those vaccines. And this is, again, a problem of delayed negotiations because, as reported in the press, a number of meetings that were scheduled between Johnson & Johnson and government were cancelled. And so there's a big delay in actually getting some sort of concrete deal to happen. And the problem with that is that these vaccine companies don't wait. They will then commit some of those doses and supplies to countries that do come forward with agreements. And so we're ending up coming in late in the day asking people to break their contracts. Now, India didn't do that with the Serum Institute and with AstraZeneca in the huge at-scale production for their vaccine. They immediately made sure they were securing a portion of the domestically produced vaccine. But South Africa, who's running trials, has a production process going on in South Africa and sat back and watched. So we need now to secure a deal with Johnson & Johnson for a portion of what's going to be produced in South Africa. And even though it's coming out in March, we would still be in a position to try and alleviate the impact of a possible third surge.
Now, Prof, the Provincial Command Council here in Gauteng cancelling their press briefing today to update us on whether or not the province is ready has been viewed as something that shows that there's chaos in our healthcare system here in this province, and the fact that, we are also going to experience a huge surge as people return.
So I think that the surge that we're experiencing in Gauteng isn't about people returning. We've got a domestically, locally generated epidemic or outbreak generated by super spreading events in Gauteng. And a lot of the infection increase, exponential increase we're seeing at the moment is already baked in. So we basically have to wait for the restrictions to work. But in terms of the province and the provinces being able to roll out a vaccine distribution program, I think we haven't heard from government at this point exactly how it would vaccinate frontline healthcare workers. And it's important to note they're on medical schemes, which means theoretically it's a private process of vaccination. And it needs for government not to have to fund, because medical schemes are essentially pay for all of phase 1, all of it. So you have to create the arrangements for that to happen. And it's unclear that people have really thought through the whole process from procurement to supply to private suppliers, because theoretically you have to buy it from somebody. If they're buying it from government, that has to be made, the pricing of that, and the distribution to people who would deliver it. And then they'd have to have a way of making sure that the priority group is receiving it, that they're advised on their second dose, that they're being tracked for that, and that they will come forward. So that is an important issue. Given that we're 1 million doses short on frontline healthcare workers, you're actually going to have to work out how you ration this unless you make up the shortfall in the 1 million doses. And we haven't heard anything about that.
Well, we appreciate the good news, but we do think that our government could do better. Thank you very much for your time. That is Wits Professor of Governance, Professor Alex van den Heever. Thank you.